Okay, so you guys, we are going to continue on our talks about chemotherapy. So we're talking about nitrogen mustards. This is one of the oldest groups of some of the chemo drugs that we had. You guys remember how these drugs work? What classification would you call them? What classification would you call the nitrogen mustards? Alkylators, yeah. So these are alkylators. Fantastic job. So basically, what does alkylation mean? What is that? What are we alkylating?
Nitrogen atoms of guanine, adenosine, and cytosine.
Wow, from memory? That's fantastic. Wow. We have a savant here. That is like 2 slides ago. Anyway, so yeah, so they're alkylating the DNA basically, right? So they're binding up to the DNA and basically preventing further replication of that, and then it's going to cause the cell to basically kill itself off, right? It's going to induce that apoptosis. So further DNA damage is going to lead to prevention of mitosis and whatnot. Some of the nitrogen mustards in this group include things like methylhydrazine, cyclophosphamide, ifosfamide. Those two get used pretty frequently, at least from what I've seen in dealing with pediatric cancers. Some other ones you might run into include chlorambucil and Melphalan. Again, these are called nitrogen mustards because they're based off of nitrogen mustard gas, which was used back in World War I. Very, very bad stuff. And it was a vesicant, right? And do you guys know what a vesicant is? Tries, but what does it cause?
Scarring?
Eventually scarring, probably. It causes vesicles, right? So it causes like a lot of blistering and the skin damage to occur because again, it's affecting those cells directly. It's binding up that DNA. So anytime that you hear something that's a vesicant, this definitely can be a big issue with like causing skin damage. A lot of these drugs, if you have extravasation of them into the underlying tissue, like it can cause a lot of damage, right? So extravasation of these drugs is really important to consider. A lot of these patients, especially if they're getting repeated doses, they get ports placed so that way they can have good central access. And that way you don't have to worry about like peripheral vein blowing and extravasating drug there. Most hospitals are going to have protocols set up for dealing with extravasation because you'll see some drugs they respond well to warm compresses, some respond better to cold compresses. Sometimes you actually have to use certain solvents to help to dissolve the drug and get it absorbed a little bit faster. So that's something won't cover too much here, but just be aware that when we mention strong vesicants, that's an important thing to be aware of from the patient safety standpoint. Anywho, methylhydrazine is one of the first nitrogen mustards we had back in 1942. I'm going to have a lot of different regimens that are on here. Don't memorize the regimens. I'm not going to have you memorize which drugs go to which cancer. That is a thing that you'll deal with more if you actually work with these patients and you're working on the regimens. Again, a lot of times you're going to find lots of different acronyms being used for different regimens, and you'll find that for this type of cancer you're always going to use this regimen or this regimen. But I'm not going to make you guys memorize that at this point. Like really focus on side effects, focus on the mechanisms of action, drug interactions, toxicities. All those things are important to know. I'm not going to ask you to memorize which ones are used for prostate cancer versus non-Hodgkin's lymphoma and all that. It's kind of outside of our scope for this class. Okay. Anyway, so again, because these drugs are affecting rapidly dividing cells, you guys remember the most common toxicities we're going to run into? Nausea, vomiting is huge. Other GI stuff. Skin causing, which type of skin specifically? Yeah, the mucosal tissue. Yeah, stomatitis you can develop, right? So you end up having the GI tract takes a big hit there, right? And then also like the alopecia and whatnot. The myelosuppression can be a big thing here as well. Again, what oftentimes ends up killing some of these patients is not necessarily the cancer itself. It's usually secondary infections they get from either being immunosuppressed from the cancer, if it's more of like a hematogenous one, or if it's we made them immunosuppressed by giving them all these chemo drugs. So again, you'll find that some of these are going to be available oral, some will be available IV. Most of the drugs that we're giving in a lot of cases are going to be IV forms. Usually you're going to end up seeing that we'll give kind of big doses at one time, and then we allow the cells to kind of recover themselves afterwards, right? Because if we continuously gave these drugs to the patient, that would eventually lead to the patient death. We don't want to do that, right? We're trying to target the cancer cells, which are hopefully dividing faster than our normal cells, and then once you knock those down, you give the regular cells time to kind of pick back up. You can see here, cyclophosphamide is going to be a very common one you run into. Cytoxan is a common brand name you'll hear, and it's used for lots of different types of tumors. So we use it very frequently for certain types of leukemia, but you'll see it used in solid tumors as well, like breast cancer, testicular cancer, etc. One of the big things to note with this drug in particular is going to be one of its metabolites. So you notice here how the drug gets broken down. The big thing you want to focus on is the fact that this acrolein molecule gets made here. And acrolein has this habit of causing a nasty side effect called hemorrhagic cystitis. Right, it's able to actually bind to the sides of the bladder and actually cause breakdown of the tissue there and cause this hemorrhage and inflammation of the bladder. So we don't want to cause that to make that occur. So we end up giving an antidote called mercaptoethane sulfonate, otherwise known as Mesna. You'll only ever hear it called Mesna. That's the brand name for that product. Basically, this will bind up the acrolein and prevent it from causing that hemorrhagic cystitis. Okay, so it's a unique kind of side effect with that one. Notice that a lot of these drugs can also cause pulmonary fibrosis. We'll kind of point some particular ones out. All the alkylating agents can do this, but there are some that are going to be a little bit more prominent in causing that than others, and so we'll point that out when we get to it. We also have ifosfamide, which is pretty similar to cyclophosphamide, very similar toxicities. It's probably not as potent as cyclophosphamide, but you will see use for similar types of cancer. One kind of unique thing with ifosfamide is you end up running into more neurotoxicity associated with this one, so you can actually have patients who have hallucinations, confusion, depression get worsened while they're on this, and so that can be kind of a unique thing that you'll see with ifosfamide. So ifosfamide-induced neurotoxicity. Other nice thing about this is that it will cause less nephrotoxicity, and so, but you'll still see a lot of Mesna being used alongside this drug. A lot of times we'll actually put the ifos or the cyclophosphamide into the same bag as the Mesna when it gets infused to the patient, so it prevents any kind of damage from occurring in the first place. And then you have Methylane and chlorambucil, again, kind of older agents, may see them used occasionally. Just be aware that, again, very similar toxicity. You're going to see your bone marrow suppression, nausea, vomiting, all those rapidly dividing cells end up taking a hit here. The next group of alkylators we have are the nitrosoureas. This includes Carmustine, Lomustine, and Streptozocin. These ones also work to alkylate the DNA, but they can also what we call carbamylate these proteins, and they're binding to the proteins and inhibiting their function, and that also leads to further cell damage and potential cell death. These are lipophilic, which is nice because they can get into the brain tumors, you can cross the blood-brain barrier that way. You can also see them used for some other things like non-Hodgkin's lymphoma and melanomas and whatnot. As far as toxicity goes, very similar to other alkylating agents here. See a little bit more myelosuppression than some of the other agents, certainly things like pulmonary fibrosis, some renal toxicity. Then, as always, secondary leukemias are a possibility when using these chemotherapeutic agents. Then we have Dacarbazine and Procarbazine. These are actually activated via the CYP450 system to their cytotoxic version. You can see them being used for several different regimens, things like malignant melanomas, Hodgkin's disease, etc. So again, looking at toxicity for Dacarbazine and Procarbazine, again here they're going to cause very severe nausea, vomiting. Remember that a lot of these drugs are kind of on a spectrum, so we talked about that emetogenicity. Some things can be very highly emetogenic, some can have kind of low emetogenic potential, and that's going to change what type of drugs you're going to use as far as nausea, vomiting meds go. We'll talk about those a little bit later. Interesting kind of unique side effects you can see with Procarbazine, you get some CNS depression, so it's usually not a very common one you see with cancer drugs, but that could be something you see there. Another one, this is a pretty common oral medication you can use as an alkylator, is Temozolomide or Temodar. You see this used a lot for malignant gliomas, and especially used in combination with things like radiation. So remember, surgery, radiation, and drugs all get used in combination depending on the type of cancer you're dealing with. Obviously, some are going to be less likely to use multiple modalities of therapy, so things like leukemias, it's really hard to target those drugs for radiation because obviously they're everywhere, right? So it just depends on the type of cancer you have and what type of modality you can use. Okay. Next we have altretamine, and this is one that requires another enzymatic activation here, so it gets activated this alkylating agent, and so you'll see this one sometimes used for ovarian cancers. It's kind of like a second-line agent. Again, here this one you can also see some neurotoxicity with, so hallucinations, confusion, things like that. And then busulfan, this one is particularly bad for causing pulmonary fibrosis. So again, all of the alkylating agents can potentially do this, but busulfan is pretty bad. So if you're here like busulfan lung, that can be a potentially fatal complication of this, right? And so again, you're always trying to balance out like, okay, well, what's the benefits of giving the chemotherapy drugs versus the risk of the toxicity associated with it, and how do you balance that out with the actual cancer that they have, right? So again, this is one of those kind of plus-minus things you have to consider for your patients. Next, we have our platinum-based compounds. The first one here being cisplatin. Again, only the patients with a really good insurance can afford the platinum ones. Just kidding, not really. So these drugs are going to be sometimes they can be used for sensitization of tumors to radiation. So in some cases, what you'll find is that you will give doses of chemotherapy before a patient gets radiation. Basically, you're trying to like kick those cancer cells into a state where they're starting to rapidly divide again. So as we mentioned, as tumors get bigger, they eventually kind of hit that plateau where they're not growing as frequently, right? They're not having as much mitosis because they kind of start to outstrip they run out of resources, they run out of room to grow, things like that. Sometimes by giving a dose of chemotherapy, you can start to kill off some of those cells and start to regenerate new growth of those tumor cells. You get a higher fraction of them who are actively dividing. That will help to get things more available for the radiation to hit, right? Because again, radiation is going to be affecting those rapidly dividing cells as well. So sometimes you'll see that used as a sensitization, so to speak. But cisplatin, again, going to be working to cause some of these cross-links between things like guanine and adenine on the same strand. So again, if you start to kind of crump up the DNA, prevents the DNA polymerase from coming along and starting to replicate that, right? Bad thing here is going to be the nephrotoxicity. So cisplatin is really well known for causing this, and so it's really, really important that we hydrate our patients very well. So it's not uncommon for patients to be getting, say, 250, 500 mLs an hour of fluid for several hours prior to getting the cisplatin, and then afterwards as well. So a lot of the regimens you'll see, there's pre-hydration and post-hydration orders set up around the chemo drugs that they're getting in order to help prevent that toxicity. There's a drug we call amifostine, which is actually a renal protective agent. I don't see this being used very frequently, but if the patient has a pre-existing renal disease, they may be more likely to get this just because they're a bigger risk. Usually lots of hydration with lots of saline is going to help flush that out and prevent any kind of damage from occurring. You can also see ototoxicity, so it can cause direct damage to those hair cells in the ear. So you can definitely want to do kind of baseline and follow-up hearing tests to make sure that's not having any kind of damage done there. In some cases, we might actually do what we call sulfhydryl rescue. So we can actually give sodium thiosulfate. It's a product that we can give that actually donates sulfur groups that helps to detoxify some of these toxic compounds. So occasionally you might do that in some cases. A couple other ones that fall in this category include carboplatin. I don't see this one used as frequently. Cisplatin gets used with some regularity, but you'll find carboplatins will be a little bit milder than cisplatin is, usually less reactive than cisplatin. Cisplatin is usually pretty bad for causing a lot of nausea, vomiting associated with it, but this one's going to be even more moderate than that, right? Carboplatin is just a little bit, it's not as potent, less toxicity associated with it. And then you also have oxaliplatin, which again is going to be working very similarly, but you can also get this peripheral neuropathy associated with it. So if you ever hear about peripheral neuropathies associated with chemotherapy, they talk about it in kind of a stocking glove kind of pattern. Again, so they're going to get it in the toes and then the fingers initially. Those kind of distant terminuses for the nerves are going to be the first ones that take a hit there. Okay, so that's usually the distribution there. So again, what are some ways that we can develop resistance to our chemotherapy drugs? One of the ways is if the drugs or if the cancer cells start to develop efflux pumps, or ways to prevent the drugs from actually getting into the cells, right? Because they can't get to the nucleus to affect the DNA, it can't really work. So they can do that. You may find mutations in the cancer cells which will actually lead to less activation of a lot of those alkylating drugs. We mentioned a lot of them have to undergo enzymatic activation. If you prevent that, that also makes your drugs less effective. And then you'll actually find some cells will start to increase amounts of glutathione that actually helps to bind up the alkylating agent before it hits the DNA. So it's kind of a natural kind of resistance pattern that can develop over time. And then also the DNA repair mechanisms can also be kind of upregulated in order to overcome the alkylation effects. Basically means if you use these drugs by themselves, you end up getting resistance, right? So that's, again, very similar to why we don't use just one drug to treat HIV. We use multiples, right? Because otherwise you're going to see resistance develop. So this is a very important point that we oftentimes will have multiple drugs being given at the same time in order to help prevent this resistance, or they'll be given around the same time. So the common drugs you'll see used in combination with the alkylating agents are going to be our antimetabolites. And so these are also going to be preventing DNA replication, but just via a different route than the alkylating agents. So some of the ones that work through this pathway include folic acid analogs. Probably the most important folic acid analog is going to be methotrexate. You guys remember where else we use methotrexate? Yeah, rheumatoid arthritis, a lot of rheumatoid conditions. Because again, it's going to be an immunosuppressant. It's going to be able to knock down our immune system. That's why we use it a lot, those kind of autoimmune conditions. So methotrexate is probably the most common one. We also have trimetrexate and then permetrexate. I've never actually seen those used clinically, but those also could be seen out there. And then you have some pyrimidine analogs, and they basically prevent the pyrimidines from being formed to be incorporated into the DNA. So you have 5-fluorouracil, fluoxuridine, capecitabine, and then cytarabine, or RSC, as a frequent way you'll hear that being referred to. So cytarabine and C are used pretty often. Every once in a while, the 5-fluorouracil, and we definitely use a lot of methotrexate for our leukemia kids. So we use that very, very frequently for them. So other drugs we can have, we have purine analogs, again working similar as the pyrimidine, but just working on different base pairs. But you see mercaptopurine, we use this one very, very frequently for a lot of our kids. Fludarabine, cladribine, we have thioguanine, and then also pentostatin. Probably thioguanine is probably the second most common one out of this list that I see being used, but you do use quite a bit of mercaptopurine for our hemo patients. So again, all of these are going to be structurally related to the naturally occurring bases, or at least some intermediates in the steps following up to forming a functional base before it can be incorporated into the DNA. And so either we're going to be working to inhibit the enzymes, or we're actually having these drugs substitute directly for the bases. When they get incorporated into the DNA, they can't be added onto, right? So basically they're strand terminators from that standpoint, where they basically get incorporated into the DNA and then there's nothing to add on to it. So the DNA stops at that point, right? So we'll talk about a couple of different drugs and how they're working through these pathways. So you're going to find that the antimetabolites are going to be working specifically during the S phase, and they will also, depending on where they're working in this process, help to impair nucleotide synthesis in the G1 phase as well, right? So the more cells you have rapidly dividing, the more of them are going to be in the S phase. You guys remember what's happening in the S phase? Yeah, DNA synthesis. So if we're blocking that, hopefully we can prevent new DNA, prevent mitosis from occurring. Okay. Sometimes you'll find resistance develops by having increased gene amplification. So for instance, with methotrexate, if I'm inhibiting dihydrofolate reductase, if I can upregulate that enzyme or production of that enzyme, I can overcome the methotrexate that's sitting around, right? Or if I can have target enzymes that have different conformations and have less affinity for the drug, that can also provide some resistance as well. Okay. So again, methotrexate being a very, very common one, we're going to call this a folic acid analog. And basically, it's been around for a good long time. We've used it for well over 50 years. And this has actually led to one of the first cures of a solid tumor. So a very, very kind of important drug from that standpoint. But again, you'll see it used a lot for rheumatoid arthritis, lupus. We'll sometimes use it for transplant patients because, again, they are also requiring immunosuppression in order to prevent rejection of an organ. So that's another place you might see it being used. So here, I'll show you a picture of this in just a second, but essentially what this is doing is methotrexate is an analog of folic acid, and it's a very high affinity for the enzyme dihydrofolate reductase. By inhibiting that enzyme, preventing dihydrofolate reductase from converting dihydrofolate to tetrahydrofolate, you prevent production of thymidine, cysteine, and then methionine as well, right? So you prevent these reactions from occurring, prevent the nucleosides from being actually produced, and they can't get incorporated into the DNA. So here's an example of what this looks like. So you have a normal process here. We have dihydrofolate reductase right here, forming tetrahydrofolate from dihydrofolate, right? Basically, you're inhibiting this enzyme when you give methotrexate. Notice how it looks pretty similar in structure to the tetrahydrofolate, so you can see why it would be able to kind of mimic that and be able to get in there and inhibit that enzyme, okay? Just based on the similar structure. But you basically prevent this from occurring unless you're going to have less like cysteine and things like that being produced. Right? Does that make sense? So how the drug actually gets to its site of action. Basically, you'll find that methotrexate, because it looks kind of like dihydrofolate, is going to get actively transported into cells, and you're going to find that because cancer cells are rapidly dividing, they're trying to produce new DNA at a higher rate than regular cells. You have kind of preferential uptake of methotrexate into these cancerous cells. You're going to find that once methotrexate gets in, it ends up having these glutamyl residues that get added onto it that actually prevent it from ever escaping the cell at that point. So it's kind of like once it's there, it's kind of stuck there. We do have a drug that is called leucovorin. The other name for that is going to be folinic acid, right? So folic acid gets converted into folinic acid. That's the active form. We will actually use leucovorin as a rescue agent after a patient has gotten high-dose methotrexate, right? So essentially, those normal cells, they will have their dihydrofolate reductase inhibited as well, right? So they're not able to produce folinic acid. We can actually just give them the active form to use that in order to make their DNA. Right? So a lot of times what you'll see is we'll give a really big dose of methotrexate. That'll help to inhibit all those cancer cells that are rapidly dividing and uptaking the methotrexate. And then afterwards you give them leucovorin to help rescue all the other healthy cells that are around. Make sense? All right. So for instance, if you ever have like an overdose of methotrexate, which I've had patients who've accidentally done that, like older patients with rheumatoid arthritis have accidentally taken multiple doses of methotrexate they shouldn't have. We actually give them folinic acid in order to help reverse those effects, right? Because we're just giving them the active form that they're not able to make themselves. So methotrexate is available oral or IV. So again, you can use it kind of on an outpatient basis, or they can come into the infusion center and get big doses of it. Again, we use it a lot in our leukemias for our peds patients. Also note, do you guys remember the differences in the doses were between, like, say, rheumatoid arthritis versus like cancer? A lot smaller in those autoimmune conditions, right? Because we don't need to like wipe out the whole immune system. We just need to kind of like tamp it down a little bit and just try to make it less active, right? Here we're trying to like knock out all of these immune cells, trying to basically just inducing like a big neutropenia and allowing kind of normal cells to start to repopulate. Okay, so again, the different doses are going to be much different. For instance, you might see someone who's like on methotrexate, say 25 milligrams for like rheumatoid arthritis. Here we're giving like several grams, like 10 grams in a single dose of methotrexate IV. So again, big difference in doses here. So obviously toxicity is going to be seen again with these rapidly dividing cells. So bone marrow suppression, you see this GI and oral epithelial ulceration, nausea, vomiting. Methotrexate can also be pretty bad for causing hepatotoxicity. So you do want to monitor hepatic function in both the baseline and see how that kind of trends over time, right? You're looking at ALT, AST. Do you know how another good way to check for actual liver function? What other tests you can run? Yeah, PTINR is a big one, right? Because again, if your liver's not producing clotting factors, your PTINR is going to start to rise. So again, that could be another big thing we look at. In case like the LFTs, because sometimes like the liver can get so damaged that the LFTs are actually dropping because of the fact that the liver has more enzymes to produce anymore, right? So using PTINR can be useful in those situations. But methotrexate has been used as an abortifacient previously, and so you may see some historical reference to that, but it is very teratogenic. Again, another good reason why you want to do pregnancy tests on patients before they get chemo. Make sure they're not going to have any issues with that. The other big thing is that methotrexate does get actively secreted into the renal tubules, and so you do have the risk, especially if you have more acidic urine, for the drug to precipitate out and cause interstitial damage to the kidneys, right? So if you guys remember back to when we talked about renal stuff many moons ago, you'll remember that this is one of the things where you give actual sodium bicarbonate along with the drug, and that actually helps to alkalize the urine and prevent that precipitation. So that way they can just pee it out normally. They don't have to worry about any of having those crystals kind of precipitating out. So Perimetrexate is just a drug that kind of is very similar to methotrexate, has very similar activity here. Sometimes you will get some rash associated with a certain number of patients, but again, very similar to methotrexate. Okay, so moving on, then we had the pyrimidine analogs. So again, kind of taking the place of thymidine, cytosine. I'm probably not going to get so granular as to ask you which one's a purine versus a pyrimidine analog. I'd really just like you to know if it's like a antimetabolite. For methotrexate, you should probably really know it's a folic acid antagonist. But just realize that I'm not going to get too super granular on that particular point. Anywho. So the pyrimidine analogs, you have things like 5-fluorouracil. So basically it's just uracil, which again is a precursor, added on a fluorine onto that 5 position there. And so we're going to see how that is going to get utilized just a few minutes here. You have cytarabine, again, which is going to be basically it's a cytosine analog, but it ends up having a little bit of change in the sugar molecule that's attached to it. So that'll be important when it gets actually incorporated into the DNA. Again, all these drugs need to be activated by the tumor cell enzymes, and then also they're going to be worked on by DNA polymerase when they get incorporated into the DNA itself. So 5-fluorouracil, when it gets attached to ribose or deoxyribose, it forms this byproduct called FDUMP. I just see FDUMP, but I like FDUMP better, sounds better. Basically, it's competing with a natural, this uracil monophosphate, or deoxyuracil monophosphate. Basically, it's competing with that and inhibits the thymidylate synthase, and thus you have less thymidine actually being incorporated into the DNA. So less the base pair actually making the DNA, more DNA damage being done, less mitosis. So you see here, this is the same step where we had, or same process where we had folic acid being utilized here. This is the step where we have thymidylate synthase working to convert this methylene tetrahydrofolate over to dihydrofolate. But here is basically where your 5-FU is going to step in and prevent this step from occurring, right? Basically just substituting for it, and thus you have less thymidine getting incorporated into the DNA. Okay. This one actually has a topical product that's available, so sometimes for certain skin cancers you will see 5-fluorouracil cream being given and IV as well occasionally. This is one of those ones where you may actually see the drug being infused over several days, and so you can see this with cytarabine as well. But essentially, by giving the drug continuously over the course of, say, 5 days, you're not going to be able to target all the cells that are in the S phase, but as they kind of gradually eventually get into the S phase, that's where you start to target them, right? So instead of giving one really big dose, like we do like for something like methotrexate, here you can give it, you know, say over 5 days, and end up targeting more cells at that point. Okay? So this is going to be better for the slow-growing type of solid tumors than you would see for something like a leukemia, which is very rapidly growing. That's why you can give big doses of methotrexate and be done, versus this one you might need to give over a long period of time because the tumors are just slower growing. So you can just notice here, again, you may have a large number of cells here, just say like in that G1 phase, and maybe in G2, maybe actively mitosing, but you have to wait for them in order to get to that S phase for them to really kick in for the 5-fluorouracil to be useful. Okay, there's a couple different varieties of 5-fluorouracil, so you may see floxuridine. Basically, it's just 5-fluorouracil with the deoxyribose added onto it, and then there's capecitabine or Xeloda, and this is just a prodrug, and this could be sometimes used for things like, you know, really resistant breast cancer or sometimes colorectal cancer. So again, they are going to do basically the same thing, they just have a little bit different means of getting to the active form. Again, very similar toxicity we've seen here. You do see, again, this hand-foot kind of syndrome, and so that's kind of associated with those neuropathies. Again, they're going to be typically starting in the fingertips and in the toes, so it can just be manifesting as paresthesias, or you can see pain, sensitivity there. You see this more frequent with capecitabine than you would with the other 5-FU products. Next we have cytarabine, otherwise known as Ara-C. So this is going to be a cytosine, which we again know is a normal base pair that is going to be attached to this D-arabinose sugar. Basically, it's going to get phosphorylated into the triphosphate form of this, right? And then once it gets incorporated into the DNA, the arabinose is not able to be elongated, basically. Basically, we're just screwing up the sugar structure, so that way when it gets incorporated in the DNA, you can't add anything onto it, and then you have this termination of the chain, and thus you're going to end up having, you know, the cell's going to realize, hey, we can't make any more DNA, let's just go ahead and cause apoptosis and get rid of the cell, okay? This is another one that you'll frequently see being given over 5 to 7 days in order to help hit the slow-growing tumors and make sure you get as many of them hitting the S phase as you can. So, other toxicity you can see with this one is pretty potent myelosuppressant, so again, you're going to see pretty big drops in your white counts. Hepatotoxicity you can see with this one, stomatitis, so again, pretty similar to what we've seen previously. Okay, another one, gemcitabine. So this is going to be a difluoro analog of cytidine that gets incorporated into the DNA strands. This is another strand terminator. Again, once it gets into there, it's not able to add on any more base pairs to that, and the DNA strand is basically done. Sorry, apoptosis. Sometimes you'll see for certain cancer regimens, you're going to notice that they will give them either say like continuous over 5 days, and then you say do it again in another cycle. Sometimes you'll see this where you're going to give it say IV on days 1, 8, 15, and 28. It kind of determine that that's when you're most likely to end up hitting those cells as they end up hitting that S phase, based on the growth rate for most other that type of cancer you're treating, right? So you'll sometimes see that the days you actually give it can differ based on the regimen you're running with. Okay, next you have the purine analogs, and so 6-mercaptopurine is probably one of the biggest ones here. This one is an analog of hypoxanthine. It gets converted into nucleotides and basically just, again, preventing that DNA synthesis once it gets incorporated into the DNA strand. Thioguanine is just an analog of guanine, does the same thing. Fludarabine, cladribine, all these things are eventually going to be inhibiting the DNA polymerase because it can't produce any more DNA. But instead of working on the pyrimidines, they're just doing the purines on that side. So 6-MP gets phosphorylated and adds onto the sugar to get this thio-IMP, and then that basically prevents any further production of things like adenosine and xanthine formation and prevents further DNA synthesis. So this one's also interesting because it can get incorporated into the RNA and you start to screw that up as well because it is working the adenosine there. So it's kind of an interesting point. This one we give very frequently orally, so you see like there's compounded suspensions. We used to have to compound this ourselves all the time, and one of the things you'll realize if you're ever kind of privy to it is anytime you have to compound these types of drugs, what do you have to worry about, do you think? Like, so compounding means like I'm taking tablets and I'm like turning it into a suspension for like a kid to take. Not first pass effect, because I'm basically going from, because it's all oral at that point. So you have to think about who's making the drug, right? And you have to think about protecting them as well, because these are considered hazardous drugs, right? All of these are going to be teratogenic. You have to worry about people who are actually making this, because when you're crushing tablets, you can have aerosolization of the particles, and so you have to make sure that people are using proper protection. They use PPE, personal protective equipment, in order to make sure they're not inhaling a lot of this drug. And so that's one of the big things we you see like on the hospital kind of administration side, make sure the safety protocols are set up. We have to do this in a hood where basically it has negative pressure, so that way we're kind of sucking in all the particles away from the people who are actually making it. So always consider the dangers to the healthcare providers who are giving this, not only just the patient, right? So it was at 6-MP, so it has a couple of different ways it's going to get metabolized. So you have xanthine oxidase that converts those purines into uric acid. So because you're doing this, you can end up seeing hyperuricemia, hyperuricosuriya, so you can end up seeing issues with that, especially if they have any previous history of gout. You can potentially have an exacerbation of that. And then sometimes we'll actually give allopurinol. Remember how allopurinol works? Remember what? Yeah, she knows. You just said, What is it? I think she has a glitch. So it works as a xanthine oxidase inhibitor, right? So if you inhibit that, you prevent the 6-MP from being broken down, and so you can actually end up having higher levels, so it can be a little bit more potent, and can also be used to decrease the uric acid levels. If you guys remember when we were talking about hyperuricemia, this is a big thing you worry about, especially with like leukemias. When you break down a lot of those cells causing apoptosis, they're releasing a lot of purines that all get broken down into uric acid, and thus you can have issues where you have hyperuremic syndrome. Tumor lysis syndrome is another term for that. So that's why we have certain drugs like that raspauricase that actually went in and actually cleaved that itself. So always have to consider kind of the secondary effects when you give these drugs. So again, very similar toxicity we already looked at. Obviously, opportunistic infections just being related back to the myelosuppression that we're causing there. Some other ones, we already mentioned these, like thioguanine, fludarabine, cladribine, again, all kind of working very similarly. You get incorporated into DNA, prevent any further DNA elongation. So, okay, so next we're going back to antibiotics. You guys remember covering that? Just kidding, we just call these antibiotics, they're not actual antibiotics. But a lot of them were actually derived from bacteria. And so again, when bacteria are reproducing, they oftentimes have to kind of fight for fight for supremacy. They have to fight off other bacteria. So some of these are actual natural products that bacteria would be secreting in order to kill off other bacteria, right? So that's kind of where the name actually ends up coming from. But some of the drugs that fall into this group, things like dactinomycin, daunorubicin, doxorubicin. Some of these are going to have like a very bright red color, like doxorubicin, and you always tell if someone's actually receiving that. Idarubicin, midazotrone, bleomycin, and mitomycin, okay? So basically this soil fungus or streptomyces, they will use basically, this could be used in people to kill off bacteria, but the problem is it's so toxic that you really wouldn't want to do that. So that's why it's really kind of relegated back toward just using it for cancerous cells. You'll have these three: daunorubicin, doxo, and idarubicin, which are anthracycline antibiotics. These are very good for different like hematologic or solid tumors, so we use this very frequently for some of our leukemia kids. Bleomycin used a lot for things like testicular, head, neck, and cervical cancer, and then you can kind of see some other things we'll use these for. So these are very, very potent agents. We're going to see there's lots of toxicity associated with them as well. So the way that these guys are working is they are basically binding directly to the DNA, and they intercalate themselves, which I really like that word, but basically they're just kind of shoving themselves in between the DNA and causing these strand breaks to occur, and it prevents any further DNA replication, right? So the base pairs aren't really meeting one another. The DNA polymerase can't produce new DNA because you're having this damage being done. So again, dactinomycin is probably one of the most potent tumor agents that we have, and again, use it for either like hematogenous, or you can use it for solid tumors, but very, very significant myelosuppression, so these pancytopenia that can occur here. These are also going to be drugs that, when they're extravasated, can be very, very bad vesicants. They can cause a lot of damage if they end up getting out of the vein and into the surrounding tissues. But you can kind of see, based on the structure here, how this is able to kind of get into the DNA and just kind of insert itself and kind of cut it open, essentially, causing the single strand breaks. Dono and doxorubicin, again, these are also going to be intercalating to the DNA, but they also have the ability to inhibit topoisomerase 2, and that's really responsible for causing those helps to repair the strand breaks, but it's also responsible for kind of unwinding and rewinding the DNA back up when it's going for replication. So that can be another mechanism there. One of the big things you'll see is with these drugs that they cause dose-limiting cardiotoxicity, and so these actually have a lifetime dose that they can receive. Otherwise, you can generate cardiomyopathy. So like echoes are really important to get on patients when you're giving these drugs, because if you start to see this, you need to stop giving the drug, right? Because the cardiomyopathy can lead to CHF and all kinds of bad things for the rest of that patient's life. So again, you can see the structure here. It kind of makes sense how it can just kind of get itself into the DNA. So other things that these drugs will do, when they get metabolized, they form these free radicals. And you guys remember, free radicals are very reactive. They like to go and bind to things like proteins and denature them and all kinds of things. So you can see how it can cause other strand breaks, denature proteins, cause all kinds of problems. And the problem with the cardiac tissue is it's usually low in the superoxide dismutase, which is usually responsible for dealing with a lot of free radicals, right? So because the heart tissue is low in that, it's not able to deal with those, and that's where you get a lot of the cardiotoxicity from. So again, frequently you'll see, like, a patient can get, say, like 550 milligrams per meter squared of doxorubicin in their lifetime, and once they hit that lifetime dose, they cannot receive that drug anymore, and then they have to go try some other type of regimen, right? So it's kind of really important to make sure that you're accounting for the fact that, okay, well, is this another recurrence of cancer? Has the patient received this drug previously? If so, you need to count those doses in as well to make sure they don't get over that lifetime limit. Okay. You see all the different types of tumors they can be used for. Notice here it's a very dark red color, so it's kind of interesting. If you ever see that, you'll know that it's definitely a daunorubicin or doxorubicin. There are some ways that we can try to limit the cardiac toxicity and try to see if we can give more drug to the patient over their lifetime. One of the ways we can do that is, do you guys remember amphotericin B? That drug used for fungal infections? Yeah, so we had the ambisome, the liposomal form, where actually we're able to implant the drug into that lipid bilayer and cause less renal toxicity. We kind of do the same thing with daunorubicin here. We have this kind of lipid bilayer kind of encapsulated around the drug, and that actually helps to limit some of the toxicity. It's a lot more expensive, it's harder to make, but that is one thing you might actually see being used occasionally. Another drug that we can give is one called dextrozocin. This drug is going to be a chelator. You guys know what chelators are? What are they? Bind things, yeah, they bind things up. So basically, dextrozocin can be given along with doxo or daunorubicin, and they can actually bind up those free radicals and prevent damage. So it's a very common antidote that we'll give along with those drugs to prevent damage from occurring. Okay. Again, these drugs have very severe vesicant properties, so you really need to be careful. If you have an extravasation, make sure you have a good line for this. Make sure, central access potentially if they're going to be getting multiple doses, because it can be really bad. Also in this group would be mitoxantrone, sometimes used for things like prostate cancer, AML. This usually has less cardiotoxic effects. It's also going to be less potent as a chemo drug, but it also forms less free radicals, which is why it's a little bit better tolerated. And then you have bleomycin. This one's actually developed from the Streptomyces verticulus. Again, very, very large molecule. See it used occasionally, but also again working as an antibiotic, working to intercalate into the DNA and causes strand breaks. So again, also generates free radicals. You can see the similar toxicity. A lot of these may not have the same kind of lifetime dose associated with it, so it's really dono and doxorubicin are the main ones you're going to run into. Idarubicin can also be lumped in with that as having a lifetime max dose. Okay. You can see some of the regimens it's used in. Okay, so the next thing with bleomycin, it has a little bit lower myelosuppression. You're going to see with some of these other drugs. This is another one that can also lead to pulmonary fibrosis, related back to this kind of chronic dry cough these patients can end up generating. I'm not really sure the mechanism for that, but is one thing that's reported with that. So just remember your B drugs tend to be pretty bad for causing pulmonary fibrosis. Also, again, you can see lots of skin reactions here, so things like hyperpigmentation, blistering of the skin, all of that is possible here as well. Okay. I'm going to go ahead and give you guys a break now. We'll come back and continue on with our talk of chemo drugs. Yes. Now I've put a dour mood on the crew. Any questions from the first half? Okay. Moving on, we have our antimitotic drugs. Can you guys guess where this works in the cycle? During mitosis, absolutely, the M phase. So these drugs are actually, some of them are derived from natural products. So I always like to point those out where they come up. So the first group, we had the Vinca Alkaloids. That includes our vinblastine, vincristine, and vinorelbine. Then you have the taxanes, which include paclitaxel and docetaxel. And then finally you have the tecans. So you have topotecan, irinotecan, and etoposide and tenipicide. And basically these are all going to be working at different steps during the mitosis phase. So a couple other drugs we're going to talk about as well are going to be these biologic response modifiers. Notice that some of our monoclonal antibodies are going to be making an appearance again, but these can also be useful for different stages in the cycle. We'll talk about those a little bit later. So first off, we have the antimitotic drugs that are going to be interfering with the mitotic phase by altering either spindle formation or the actual degradation of the mitotic spindles. You guys remember the pictures where you see like the two strands of DNA, or the two sets of DNA come together, and then the little strands kind of beam out and they kind of pull them apart, and then you have two new cells, basically either preventing the production of those tubules or preventing the degradation, right? And then you'll have some drugs that are going to be working on topoisomerase either 1 or 2, and basically we know topoisomerase is responsible for causing strand breaks, allowing for relaxation and recoiling of the DNA. Some of these you're going to see have the ability to work through S phase and also G2 as well. So again, just if you need another painful reminder of what the cell cycle looks like. Again, antimitotic drugs working here specifically in the M phase. Basically the topoisomerase inhibitors working through G2 and S. Okay, so these drugs are going to be working specifically to inhibit the mitotic spindles. So you have like vincristine, vinblastine. These are actually derived from the periwinkle plant. Right? So again, if you ever get to go out to like Lou Gardens, like I always had a fun time pointing out, like, oh, that drug is a chemo drug. Oh, that one's poisonous. That'll kill you. And this, so you see all kinds of stuff. And then you have your taxanes. So things like paclitaxel is actually derived from this western yew tree. So I remember when I got to go to Ireland for a wedding anniversary. We saw a bunch of these yews that were growing out there. So it was actually kind of cool to get to see different plants in different areas. So, but yeah, the European yew is what we ended up seeing over there. It's just a humble brag to say I got to go to Ireland. That was a lot of fun. I'm just kidding. Next, you have the topoisomerase inhibitors. So these are going to be things like etoposide. This actually comes from these products called podophyllitoxins. They get made in the mandrake plant, right? And then you have tenipicide and topotecan. Again, these are kind of just analogs of etoposide. So again, with the mitotic agents, it can interfere with the microtubules and prevent the separation of the DNA strands. So if you prevent that from occurring in the first place, basically you just halt the whole cell division at that point. And when you stop it at that stage where they can't pull apart, that induces cell death and apoptosis. So again, fun picture here where you normally see mitosis occurring. They kind of pull these different genes or pull the different chromosomes apart. Again, the Vinca Alkaloids are going to be working specifically on blocking the assembly of the microtubules. You're going to see the taxanes that block disassembly. Okay, so a little bit different, in their mechanism there. So again, the Vinca alkaloids, these are primarily given IV. Note that they do not cross the blood-brain barrier. Okay, that's actually a very good thing because you're going to find that these are drugs you do not want to give to the CNS. We'll talk about why that is in a second. Note that these are going to undergo pretty extensive hepatic metabolism. They get excreted in the biliary tract, so you may need to watch out for hepatotoxicity from that standpoint. Used in lots of different tumors. We use vincristine like all the time for our patients. We use very, very frequently for leukemia. This is probably like this, and then like methotrexate is probably like the top two drugs we use for our leukemic patients. So the toxicity, very similar. You're going to be seeing lots of similar things like the alopecia. You can see the stomatitis, things like that. The other big thing is you're going to have, due to the rapid cytotoxic effects, you can have like on your hematologic cells, you can end up seeing this hyperuricemia. So this is another one where you may give allopurinol to help prevent that from occurring. These are also going to be big vesicants as well, so you've got to be careful, make sure these do not extravasate. These drugs do not give intrathecally because this can actually lead to fatalities, right? So this is one of the big medical errors that there's lots of things put in place to make sure this does not happen. So for instance, just in general, chemo being such a high-risk kind of procedure in the first place, for instance, our process at Nemours, when someone wants to get chemotherapy, actually no one wants to get chemotherapy, when we want to give chemotherapy, you have to have two providers sign off on it, right? So right there you have two checks. You have to have two pharmacists check off on that process and make sure that all the orders are correct, make sure everything's in the right solution, make sure it's concentrated appropriately. Then you have to have two nurses sign off on the drug when they're actually giving it to make sure they're giving the right drug, the right dose, right patient, all that good stuff, right? So you've already got 6 people already checking it to make sure that the patient's getting the right thing, okay? We were having medical errors because one of the common regimens that we, not us personally, but this is like something that's happened in the past, and the reason why we have a lot of these processes in place is that very frequently for some of these leukemic kids, they would end up getting vincristine IV at the same time as they're going to be getting intrathecal methotrexate, right? So basically, they would go to the OR, they'd have a LP place, the hemonc docs would inject the methotrexate into the epidural space, but they're having errors where you'd have the vincristine being injected as well, or instead of, and that led to the fatalities. So big things that we do nowadays is like, for instance, when we give the drugs over to the nurse or whoever, we don't put the vincristine into a syringe. We only ever put it into a bag, because a bag is not something you would ever hook up to an LP, right? Only syringe you would ever do that with. So little things like that to make sure, we have big things on the label say, fatal if given intrathecally, all those kind of things. So if you see things like that and you're like, well, why the heck are they making such a big deal about this? Probably because someone's died from it before, and that's why they have to. Unfortunately, that's usually the impetus to a lot of medical safety changes that occurs because someone probably died from it. So this one, vincristine, also will cause that kind of dose-limiting neurotoxicity. So again, the hand-glove kind of distribution is going to be the thing you're going to see here. You can also end up having things like facial palsies occur, muscle weakness. So neuropathies are a big thing you want to watch out for. Here, minimal myelosuppression for the most part, but the neuropathies can be the big thing. Vinblastine is going to be a little bit better tolerated than vincristine will be, and then there's vinorelbine that gets used occasionally. Probably only seen it used like maybe once or twice. Next you have your taxanes. Again, these are working on blocking that degradation of the microtubules, basically stopping the M phase leading to apoptosis. So myelosuppression is going to be the biggest side effect with these guys. Some patients may develop hypersensitivity to things like the Trexalls, and then they can also have some neuropathies associated with it as well. Okay. Next, you have the topoisomerase inhibitors. These are kind of easy to remember because they have topo in the name already, but etoposide, tenepicide. Again, these are going to be working anywhere between S to G2 phase, and by blocking those, the topoisomerase enzyme from working, prevent the strand breaks and leading to eventual enough DNA damage to lead to apoptosis. So, you're going to see that used for several different types of cancers. Etoposide can be given orally and IV. It does have pretty significant renal excretion, so you may need to watch out for your renal function for some patients there. And as far as toxicity goes, you will see pretty significant myelosuppression, so that can be dose limiting. A lot of times what you're going to find is that some of these cancer patients, they have to meet counts before they can get their drugs, right? So especially for some of these that can cause pretty significant myelosuppression, you have to wait in order to make sure the patient has recovered enough of their immune system before you give them more chemo. So oftentimes you're looking at their absolute neutrophil count. You're making sure that has recovered up to a certain point before you give them any more drug. So if you ever hear that term meeting counts, that's usually a big thing. Sometimes you'll look to see like if patients have been hydrated well enough, and they'll look at things like specific gravity of the urine to make sure that they have enough hydration to make sure they're not going to like precipitate out methotrexate and things like that. So those are sometimes kind of things that patients have to meet before they can get their drugs. Okay, next we have the irinotecan and topotecan. Again, these are going to be working to inhibit topoisomerase 1, again leading to those single strand breaks. Again, you can see used in lots of different types of cancers here. A little bit different in metabolism and excretion, but nothing too big there. Again, you're going to see this is actually one of the unique things with this one is the fact that diarrhea can be really, really bad with this one. So irinotecan specifically, much more so than topotecan, but that can be a pretty big side effect for a lot of your patients. Again, considering that they're already having a lot of GI tissue damage already being done, right? That can already lead to diarrhea by having kind of sloughing off of those cells. This can make it even worse. Okay. So that's kind of the original kind of non-synthetic, non-biologic products. Next, we're going to be kind of moving into more kind of biologic-based products here. Okay. So some of the benefits of going to these drugs is the fact that we're going to be able to have much more specific mechanisms of action. So again, it's very similar to like when we were looking at drugs for rheumatoid arthritis, right? You guys remember the differences in toxicity between like the monoclonal antibodies and say something like methotrexate? Which one had less? Monoclonal antibody, right? Because it was targeting very specific, like, hey, I'm affecting this CD receptor, or I'm affecting this particular cell, versus affecting every single cell and hoping you just deal with the ones, the problematic ones. A lot of these biologic products are going to be very, very specific in targeting cells. You're going to find that they're more limited in scope in what different types of cancers they can treat, but they're also very specific and usually have less side effects associated with them. Okay. So a lot of these drugs are going to be working on specific protein kinases. We know that there's lots of different ones that get produced anyway with our body. The genome codes for about 550 of them. And so this is really, really critical in doing cell transduction pathways. Okay, so we're going to see some that are going to be affecting tyrosine kinase. And so again, this can include things like insulin receptors, epidermal growth factors. These are all really important signals that need to be affected in order to help these cells to stop dividing, right? A lot of times these pathways end up getting interrupted, and that's why they're kind of growing unchecked. You'll also see some of them are going to be working on some of these enzymatic tyrosine kinases that affect other types of processes, like this MAP pathway, this RAS pathway. So we'll talk about some different drugs that affect these specifically. So again, we did not cover this because you guys didn't have my pharmacodynamics class, but essentially a tyrosine kinase receptor, it's a secondary messenger signaling. So basically you have a signal molecule come here, ends up you need two molecules of it to bind to these tyrosine kinase receptors. Once they're bound, they connect together, and then they get phosphorylated, right? Once they're phosphorylated, they're able to have kind of secondary messenger effects. They're able to kind of tell things downstream, hey, upregulate promotion of this protein, or stop making this enzyme, and things like that. So this is the kind of the process that we're going to be targeting here by inhibiting a lot of these different specific types of tyrosine kinase receptors. So again, another idea how this can work. A ligand binds to these receptors, causes the phosphorylation, and then you get all kinds of downstream processes occurring here. Just giving you an idea of what this kind of looks like on a kind of more large scale kind of look. Don't memorize this slide though. Okay, some examples of some of these biologic response modifiers. So one that affects the myeloid tyrosine kinase inhibitor, this is going to be imatinib or Gleevec. Some of these have kind of like revolutionized treatments for specific types of cancer. So things like like CML, right? Have you guys covered your other types of chemo stuff before? Okay, so like CML, what is that? Yeah, it's a chronic myelogenous leukemia. You're going to see that different patients will have different subsets of it based on the types of mutations that they have. So you can actually find that patients that have this BCR-ABL mutation, they will be responsive to Gleevec. So you can actually do a test beforehand, see if the patient expresses this mutation. If they do, this drug is perfect for them, right? You give it to them, basically will end up leading to the cure of their cancer. If they're not expressing this mutation, then you can't use the drug, right? So usually there's a lot more testing that goes on before you can use this potentially. But basically, by inhibiting this receptor, you have less myeloid tyrosine kinases that will signal cell proliferation. So you end up stopping a lot of the cell division from that standpoint. Again, looking at the side effects, much better tolerated. Maybe some nausea, vomiting, maybe some edema, but you don't see the same kind of alopecia, myelosuppression. It's going to be much better tolerated. Another good example of this would be one that affects the epidermal growth factor tyrosine kinase receptor, and this can be gefitinib. You can use this one for things like non-small cell lung cancer. And again, note very limited side effects, maybe some dry skin, some nausea, vomiting, but very well tolerated for the most part. And then another one's a HER1 or ERB1 EGFR, which stands for epidermal growth factor receptor. I have erlotinib, and this can be used for things like lung cancers and pancreatic cancers. Again, very well tolerated. Maybe some hepatic injury, maybe some elevated liver enzymes, but nothing too significant. You have one called lapatinib here that is affecting this ERB1 or HER1 and HER2. So this one can be sometimes used in combination. Again, you're using multiple drugs usually for these regimens in order to help get some synergy there. So for instance, this one can be used in combination with capecitabine. You guys remember what type of drug that was? It's an anti-metabolite, right? So it's kind of related back to the 5-FU that we talked about. But basically, you can see here how it actually increases the tumor time growth. So anywhere between, went from 4.4 months for doubling to up to 8 months, which is pretty good. All right, so again, these are just more targeted, affecting a single receptor as opposed to affecting every single cell that's out there. So a lot of cells, if they don't express this receptor, they're not going to affect that cell whatsoever, right? So that's kind of the nice thing there. One that is a proteasome inhibitor. This is bortezomib. This is one that's kind of interesting. We're actually doing several studies on bortezomib in some of our chemo kids. Again, I mentioned the Children's Oncology Group, and like most of the kids that get chemo from us end up getting enrolled into one of these studies, and so we have some investigational studies looking at this drug is approved for adults. We're doing some studies looking at their use in children. So it's kind of some of the fun stuff you get to do in a kid's hospital. But basically, this one is affecting this IKB receptor and is decreasing these NFKB cell survivor promoter genes. So by inhibiting that, that's actually helping lead to further apoptosis of those cells. Okay, so then moving on, we then have our antibodies. So you guys will notice that some of these drugs look a little familiar. Do you guys remember rituximab? Seen that one before. Again, these are all monoclonal antibodies. So again, they're just antibodies that are specifically designed for a single target. You guys remember normal side effects you can see with these? Yeah, so you see anaphylaxis, right, because these are foreign proteins, right? So that can be one thing. What else can you see? Yeah, immune suppression can be another big one, right? So we're going to look at some of those and see how those kind of factor in here. So again, these drugs, while they're not necessarily killing off all these cells, they can still lead to immunosuppression by preventing activation of a lot of those immune cells. So you guys remember rituximab. This is working specifically against that CD20 antigen and helps to clear those beta cells, right, those B lymphocytes. And so basically by inhibiting that CD20, you prevent that cell cycle activation, prevent them from replicating, which is good. Notice here that you can lead to this lysis of the cells because they're basically just not functioning appropriately, lead to apoptosis. You see some cytotoxicity associated with that. Again, these drugs are going to be, because they're protein-based products, they have to be given IV or given sub-Q. So again, this was one of those ones that you have to come in, sort of several infusions, say weekly at first, and sometimes they may be able to space that out some. But again, just note things like the immune reactions you can have to it, things like flu-like syndrome, things like that, probably the most common side effects you're going to run into. Next one, you have alemtuzumab, which is affecting CD52. This is affecting both T and B lymphocytes, so this can be used for those types of lymphomas. Again, notice that we're using it for a much narrower scope of cancers than you could see with things like methotrexate or things like cytarabine. Again, very similar effects you can see here as adverse effects. Opportunistic infections probably being one of the big things you're going to be looking for anyway. You have trastuzumab or Herceptin. This one's going to be affecting this human epidermal growth factor 2, is HER2. So this can be used sometimes for breast cancer tumors that express this HER2 oncogene, right? So if they express this, they're expressing that receptor, this can be useful for those types of breast cancers. They don't have that receptor being expressed, and the drug's not going to work for them, right? Again, used in combination with things like doxorubicin and Taxol. So again, using multiple mechanisms in order to help target these cells. And so you can see for those patients that express this this receptor, they end up having overexpression in those breast cancers. And so about a third of those patients end up being responsive to this. Next, you have cetuximab, which is affecting also its epidermal growth factor receptor, or HER1. Again, sometimes used in certain colorectal cancers, head and neck cancers, and very similar toxicity. Then you have bevacizumab, or Avastin. You guys can practice saying these, you get better as you get more practice with it. But again, this one's going to be targeting that vascular endothelial growth factor. So basically, this is a receptor responsible for triggering angiogenesis. You inhibit that, you kind of choke off the blood supply to a lot of these cells, prevent them from replicating from that standpoint, right? Basically, cutting off nutrients, cells are going to start to die off. This one's kind of interesting because you can see severe hypertension associated with it, right? So it's not just affecting necessarily, VEGF is not just seen with cancer cells, but you kind of see it all over the body. So you can actually see severe hypertension, proteinuria, and CHF associated with this one. So be very careful in your cardiac patients. Then you have gemcitabine ozogamycin, or Mylotarg. I know I sound like I'm spouting off like Lord of the Ring characters or something. The orc gemcitabine. Basically, this is one is targeting against CD33, and it's this antigen is linked to ozogamycin, also which is itself a cancer drug. It's an anti-tumor antibiotic, and basically for those that have CD33 positive AML, in the first relapse you can give this. So it would be for patients, not first line, but if they have a relapse of their disease and they express the CD receptor, then you can use that. Okay, and then this one's going to have a little bit different mechanism here, but it's against another biologic product that has to be injected. It's called D-L-asparaginase. You may see a pegylated form of it called PEG-asparaginase, but basically the way this is working is that asparagine is needed in order to produce protein and just in general cell division and cell function. You're going to find that normally normal cells are going to take up asparagine from the plasma, and they can synthesize it themselves, right? So you can see here, in the bloodstream, asparaginase can help to convert asparagine over to aspartate. Normal cells can convert aspartate back to asparagine. They can do that no problem. What you end up finding is that in some of these like lymphoid tumors, they have very low levels of asparagine synthase, so they have, if they don't get asparagine, they can't use aspartate at that point. So basically, you kind of starve them as aspartate. They can't produce new proteins, and they die off, right? So in that way, you can be targeting cancer cells over regular cells by the fact that they just kind of lack this enzyme. Okay, so it's kind of a unique kind of mechanism there. So I do see a fair use amount of this in childhood lymphocytic leukemias. Again, used with things like methotrexate, doxorubicin, vincristine. So again, lots of combination drugs you see there. This one is very, very expensive. Again, all the biologic products are very, very expensive. I think we probably only use this one maybe once or twice a quarter. And if you look at all the drug expenditures we do at Nemours in total, this one still comes up being like the #1 drug that we spend the most money on, right? So this one's super, super expensive. You know, be very, very careful when you're administering, especially if the patient has an allergic reaction to it and you have to end up wasting the drug. It's kind of a bummer. But yeah, so it's kind of an interesting one there. It can cause pancreatitis, intracranial hemorrhage, so definitely some side effects associated with that. And then we've talked about this previously when we talked about the OB-GYN stuff, but certainly you can use certain hormonal drugs. So using steroid hormones to affect these types of hormone-responsive types of cancers. So what kind of cancers come to mind for this? Endometrial cancer, breast cancer, things like that. Yeah, so again, depending on what type of, and you guys know what type of drugs we'll be talking about in this section. Just remember the SERMs. Tamoxifen, raloxifene. Yeah, so again, by affecting different types of hormone receptors in different tissues, you can have either prevention of cancer potentially or treatment of. So again, by sometimes we'll give glucocorticoids. This actually helps to suppress the white blood cell production. That's where we mentioned using prednisone or dexamethasone very frequently. So that can be useful in treating leukemias. You see that pretty commonly. And we mentioned things like anti-androgens being used for testicular or prostate cancer, anti-estrogens. Again, not only is it just receptor antagonists, but you can also have enzyme inhibitors as well. So you guys remember like the aromatase enzymes. You guys remember like 5-alpha reductase inhibitors. Those can all be useful here as well by limiting the supply of steroids that can be affecting the cells. So big one is tamoxifen. This kind of was pretty revolutionary when it first came out for those patients with breast cancer, and basically just competes for estrogen at the receptor site, right? It's going to be an antagonist in the breast tissue, but it's going to be an agonist in the uterus, and it's going to be an antagonist at the bone, right? So you're worried about things like developing, osteopenia, osteoporosis, and all that. So you got to be real careful with these drugs and look at who's kind of the prime candidate for them. Again, seeing things like hot flashes, as we were just kind of talking about. You can see DVTs as well due to the pro-estrogen effects it can have on certain tissues, pulmonary embolism as well. So obviously be careful with that. And it can have some positive effects on the cholesterol, right? Terimifene is another one. This one's actually a tamoxifen analog, and it is also useful for some estrogen-dependent tumors. Then we have raloxifene. Again, this is going to be selective. This has estrogen effects in the bone, in the cardiovascular system, but it will help to antagonize the uterine and breast cancer tissue. This one probably more mainly see for either prevention of breast cancer, or you can see use for osteoporosis. And then we have fulvestrant. This is a selective estrogen receptor downregulator, or SERD, I guess. And this one actually is given as kind of a monthly injection. This is a pure anti-estrogen, and so as you might imagine, you can see the kind of side effects associated with that. Hot flashes being a pretty big one. A lot of vasodilation, nausea, headache associated with that. And then we had, of course, I had a picture covering that up. I'll move that. But you have anastrozole and letrozole, and these are going to be aromatase inhibitors. Basically, by inhibiting aromatase, you prevent production of the new estrogens, things like that. So again, you can end up having kind of pro-androgen effects because you end up having more androgens floating around, and obviously the anti-estrogen effects you're going to see there as well. So osteoporosis, hair growth, things like that. Then we have exemestane, which is another aromatase inhibitor. This one's irreversible, so this one can be even more potent in dropping down those estrogen levels very, very significantly. Again, a lot of the aromatase inhibitors are getting kind of supplanted by the SERMs, but you may still use them for more treatment-resistant patients. And then here's some anti-androgens. We have like flutamide, nilutamide, and bicalutamide. These are just blocking the androgen receptors and preventing testosterone from interacting with those. Obviously, you're going to see more kind of pro-estrogenic type of effects because you're having a relative lack of testosterone activity. So you see gynecomastia associated with that. Usually, you end up giving these drugs like leuprolide or goserelin, which are going to be the GnRH mimics that help to decrease LH and FSH secretion, right?
Can these be used for women that are having like because of androgens?
I don't know that I've ever seen that being done because, obviously women are going to have some degree of testosterone. I don't know if the side effect profile would really make it worthwhile from them. So I don't know if that's the case or not. But if you talk to an endocrinologist, may have more answers for you.
I know.
There you go. And so I mentioned leuprolide and goserelin is just going to be the analog of GnRH, goes and kind of activates that inhibitory feedback loop to end up decreasing FSH and LH. So basically, it's able to kind of shut down production of things like new androgens and estrogen, depending on the gender of the patient. Okay, and then there's some immunotherapy. So sometimes you'll find that we mentioned some of these cells are going to be expressing certain proteins on the cell surface, and so you can actually have drugs that can specifically target that. You're going to find that while your body wants to attack some of these kind of cancerous cells, you'll find that the tumor cells end up being less antigenic than foreign cells, which kind of makes them kind of elude the immune system to some degree. But one thing that we can do is help to stimulate the immune system in order to help target those cells a little bit more aggressively. So we can use things like interferon. You guys remember interferon?
Depression.
Causes depression. Yeah, we don't like to use it. Where else do we see it being used?
Hepatitis.
The hepatitis?
Hepatitis.
Yeah, hepatitis. Yeah, we use it. The emphasis was on the wrong syllable. Yeah, so we use it for hepatitis. Used to use it much more for hepatitis C. You also saw it used in multiple sclerosis, right? So lots of different places there. But you guys know this just increases the cytotoxicity of our own immune system, try to help take out those cancerous cells. So there's some specific types of cancers you may see this being used occasionally, but it's not super common, at least as far as I'm aware. But again, we know that, again, it's a sub-Q product because it's a protein that we're injecting here, and lots of side effects associated with like the depression, mood changes, and things like that. flu-like syndrome, especially because again you're kind of kicking up your immune system, trying to get, be pro-inflammatory. So again, you're going to be experiencing those kind of flu-like symptoms associated with that. And then one last one, we have aldesleukin, which is basically interleukin-2. Basically, this is kind of serving, interleukins normally kind of serving as a molecular messenger between different leukocytes. If you're able to, I think interleukin-2 specifically can be a T-cell growth factor, so you can actually end up inhibiting this by giving aldesleukin and preventing that cell proliferation. So that can be one way you can target that as well. So again, here by giving this, you can actually stimulate proliferation, activation of some of these killer cells, and then go through and help to target the cells, help them to kind of take out the cancerous ones preferentially. And so this one again is going to be an IV infusion because it's a protein, and you end up giving it over several cycles in order to help target those cells. Again, all these products are usually recombinant products. So again, there's things that our body's making, but usually we task E. coli and things like that to help produce it for us, which again makes it very, very expensive to produce. And again, you may see it used in some things like renal cell carcinomas. Again, very, very specific types of cancers you're going to use this in. Again, very similar adverse effects here because again we are stimulating our immune system, so you're going to see a lot of flu-like syndromes. You're going to see potentially risk for arrhythmias, MI, and heart failure. So again, very, very toxic drug, used very occasionally. This one's kind of interesting here. This capillary leak syndrome that can occur. So you can see very severe hypotension that may be requiring vasopressors to be added on. So things like dopamine or epinephrine in order to help bring the blood pressure back up, right? Because they're going to be just leaking out all their fluids into the extracellular space. So you have to be very careful when using it with patients with cardiac histories or pulmonary problems, seizure disorders, because again, it can exacerbate all those conditions. And so again, just be very, very careful with this drug if you ever end up using it. Okay, so that's it for the cancer drugs. Not my favorite topic ever, but yeah, so lots of drugs. So be able to kind of pick out like what their mechanism is going to be, if there's particularly unique side effects. So again, just to say like, oh, this one causes myelosuppression. Well, guess what? Almost all of them cause myelosuppression. It's not super unique. If it's like, oh, this causes capillary leak syndrome, that's pretty unique. I should remember that. Or if it, so things like that. And then just in general, like monoclonal antibodies. These causes immunosuppression. I can see secondary infections from that. I see that with a lot of the drugs actually. Yep. So, anywho, so any questions on that section? Okay, I'm going to go ahead and record the last section. It'll be on prescription writing and geriatrics and peds. I will attempt to throw in jokes and stories, and while I look at a picture of you guys on the wall, and then we will have the review next week. Okay, see you guys next time.